ask, one of the issues that's pertinent to the lung cancer population is the issue of age. You know, both in terms of efficacy of anti-angiogenic agents as well as safety. And I just wanted to get, I'll start with you Eddie, your perspective on that elderly patient.
Sure. So that has been sort of a part of the analysis for the data sets that have led to approvals of both bevacizumab in the frontline setting and ramucirumab in the previously treated setting. There was a subset analysis from the E4599 study that indicated that the benefit of bevacizumab was in patients who were younger. The age cutoff, I believe, was 70 there, and in different cutoffs have been either 65 or 70. Ramucirumab, it was also evaluated that in terms of based on age, again, looking back after the study and seeing what the differences were. And some of the results were consistent with the E4599 study when one looks at survival. And in general, I agree with what everyone has said, that the tolerability has been quite good. There, of course, are concerns about coronary artery disease, other things that do tend to be more common as patients age. But I think that some of those things are still exploratory, but certainly now across 2 registration trials, we've seen the greatest benefit being in patients who are younger. However, these are based off of subset analyses, and the confidence intervals are large.
Yeah, small numbers. Roy, your thought of age?
I would agree. Again, you know, with age, it's not really how old the car is, but how many miles are on it.
Right, yes. Yeah.
Although that's not entirely true
Yeah.
in cancer, so you got to be a little careful. But again, do you have a compelling reason to use it? I think that's the question. And you know, this is a good regimen. It's been used for a long time, but in the absence of a biomarker, I think what I've seen is a trend, at least in the practices in our area, is that with the added benefit is rather small. With the potential for side effects being rather high, so I have seen people sort of move away from that.
Right.
And in the non-squam, tend to use more of the carboplatin pemetrexed. And then in the squams, of course, where we haven't really used that, you know, we're looking for new things.
Yeah, Dr. Langer, a good friend of ours, did a combined analysis of ECOG 4599 in Point Break, and really looked at the cut point of 75, and it was really above the age of 75 where, again, small numbers, subset analysis, there was not clearly an efficacy benefit, and there were real concerns about toxicity in the older
Right, the hypertension that
yes,
you have to
all
deal
these
with.
sorts of things. Is this a concern to the colon population?
Certainly almost the opposite for colon.
Oh, really?
Is what we've seen is, so in our subset analysis, the elderly
Do
or
better.
older patients still do better with the addition of anti-angiogenics. And in fact, there was a study called the AVEX, I'm not sure how they pronounce it, it's British, where they looked at patients who were over 70 and not candidates for doublet chemotherapy, and they randomized them to capecitabine plus bevacizumab or capecitabine alone. And what was very interesting about the study is that the patients all got benefit from bevacizumab. There was a survival benefit, there was a significant progression-free survival benefit, and there was also a response rate benefit. So certainly for colon cancer, maybe it's a little bit different. And we also have seen there were a lot of studies looking at the arterial thrombotic events. Yeah. And for the patients who are at higher risk were patients who are 80 and above, and also had a risk of coronary artery disease. So tying in all of the potential toxicities.
Comorbidities are important,
and comorbidities, it's a different story. But for colon, we do see that benefit even in an older population.
And I'd like to add in terms of when not to do it. So there are 2 large studies in colon cancer in the adjuvant setting where the addition of antiangiogenic therapy was proven not to be beneficial. And you know, just for all of our viewers, it's important to know that, you know, these aren't completely benign drugs. There are side effects, hypertension, and, you know, risk of blood clots and things like that. And so, in the adjuvant setting, it's one area where it hasn't been proven. In lung cancer, is that true?
Well, yeah, the same exactly in lung cancer. We had ECOG 1505 that Dr. Wakely presented in Denver at the ISLAC meeting. And I think there were 2 curves there, although they were completely superimposed in terms of overall survival. But absolutely,
took a long time.
Yeah, absolutely no benefit in the adjuvant setting. And this was a year of of use. So similar to the colon
I
story.
think probably in lung, it's probably not quite as good a drug. And so the therapeutic index is a little smaller.
Right.
And again, what we really need in lung is some sort of biomarker.
Right.
There's no doubt the drug has effect, but
Right.
and that's been the elusive search for, what, 15 years, right?
In gastric cancer?
Well, in gastric cancer, bevacizumab came close, but no, not close enough. Avogast study was a large, and the phase 2 data looked very promising, and our own Manish Shah generated, some of it. So when it was explored in phase 3 study, in the large Avogast study, what that study is really showed a significant trend toward improvement in all outcomes, such as response rate and PFS, but the primary endpoint was not met. And there's a lot of data out there, and again, this is another validation of that observation, that gastric cancer is extremely heterogeneous disease. And the gastric cancer in the Western population is a completely different disease. It may be as, if we're trying to, draw a parallel between EGFR mutant adenocarcinoma of the lung versus KRAS mutant. It's just the Western population gastric cancer, it's more proximal tumors, G-junction tumors. They're more aggressive, and they're probably more VEGF driven.
Yeah.
And so if you looked at the subgroup analysis of patients from the Avogast for our patients, Western patients, and in U.S. and Europe, there was a very robust benefit. And interestingly, our experimental arm, the bevacizumab arm, did worse, or just not much better than their comparison arm, the Asian, placebo arm, the Asia placebo arm, because again, really highlighting the fact that gastric cancer in the U.S. and the Western world is a more aggressive illness, and perhaps these biologic agents, particularly VEGF inhibitors, have more of a role in our disease because they're more proximal tumors. The gastric genome atlas shows that they're morphologically and molecularly completely unique. And learning from these sort of observations, the ramucirumab trial really limited, and a lot of future trials in gastric, they put a lid on how many what percent of a population in each trial can be accrued in Asia, because Asia, it's a large market, and so they can quickly accrue trials, but the benefit may be diluted.
One plug I'll make then for when we're talking about differences in data from Asia, for a trial that I'm involved with, is that there is some data now about the role of angiogenesis inhibition in EGFR mutant non-small cell lung cancer, which of course is a considerably more common disease in Asia. This is something that has been evaluated over a long period of time, but there's recently been data out of Japan looking at bevacizumab. Data with both bevacizumab and ramucirumab is being evaluated as well in combination with erlotinib or other EGFR inhibitors in EGFR mutant non-small cell lung cancer.
Yeah, we saw that many years ago in the beta trial, which actually took bevacizumab, erlotinib, that the results, the hazard ratio was in the 0.6 range for time to progression. There just wasn't a survival benefit. The question is, was it crossover? Why did that occur? But I would agree with you, that's something worth studying.
Yeah, that Japanese trial, there was an incredibly impressive difference in PFS with that. But I've not seen any survival data from that.
No, and I guess there was a U.S. trial that's trying to...
Yeah, that's accruing. It's getting there. And I believe there's a European trial too. I can't remember the name of it. But I think the plan, at least with the U.S. and the Japanese trial, was to combine that data at some point.
Right, and EGFR resistance, there are still 50% or more of patients become resistant with EGFR mutant lung tumors, for which we don't have
A good plan.
A good plan, yeah.
Yeah.
So it's